Cameron Whitcomb, who let us in with options today, has a bunch of songs on Spotify, super cool artist, and he sings very frequently about overcoming addiction, which happens to be the theme of this week's episode. So, I won't keep you guys waiting any longer. Let's get going. Have you ever been at work watching the clock because you just couldn't wait to get home? Or been on a diet and found yourself thinking about that cookie in the break room all day? Most of us know what it's like to crave something. That little pull in the back of your mind. It's easy to ignore at first, easy to laugh it off, until it isn't. Now imagine that feeling doesn't just linger in the background, it starts to take up space. Not just a thought you notice occasionally, but something that keeps tapping you on the shoulder over and over and louder each time you try and push it away. Every hour becomes a negotiation with yourself, not just about waiting, but about trying to stay present at all. You're trying to go about your day, and it's in a constant loop that runs in your head, pulling you out of conversations, out of work, and out of sleep. You're there, but you're not really there. And every time you win that argument, it costs you something. Like you're holding your breath a little bit longer than you thought you could. And then eventually, you stop fighting. Not because you wanted to, and not because you don't care, but because for just a little while, everything feels normal again. The noise quiets, the loop stops, and your brain finally exhales. This is a feeling that some of our patients know far better than most of us ever will. And by the time we meet them in the back of the ambulance, we're seeing one moment in a battle that's been going on for days, weeks, maybe even years. We see the overdose, the intoxication, and the withdrawal. But what we don't see is maybe the hundred of times that they tried to make it just 1 hour longer. Managing chronic pain is one of the most difficult challenges in today's healthcare system. Picture a primary care physician who's been seeing the same patient for years. They've had surgeries, tried physical therapy, and seen specialists, but they're still in pain. The medication that helped them at first, over time has stopped working as well. And the patient isn't asking to get high. They're asking to be able to work, hold their grandkids, or walk through the grocery store without stopping every few minutes because they're hurting. And now the provider wants to help. So another prescription gets written, then another, and slowly things begin to change. A helpful way to understand chronic pain is to think of it like a smoke alarm in your house. When the battery starts getting low, it chirps every once in a while. It's annoying, but you can live with it. Now imagine that the smoke alarm in your kitchen starts going off. Suddenly, alarms are going off everywhere. And nothing really changed in the house, but the entire system has become way more sensitive. That's very similar to what can happen with chronic pain. Over time, the nervous system becomes sensitized. The threshold for pain gets lower, and what once required a significant injury to trigger pain may later be set off by a much smaller stimuli, or sometimes no obvious trigger at all. The body's alarm system becomes overreactive and much harder to reset. Eventually, both the patient and the provider reach difficult crossroads. The medication isn't working like it used to, and increasing the dose isn't safe. So the conversation shifts towards pain management, physical therapy, injections, surgery, non opioid options. And for some patients, that's where the search begins. They may go to an urgent care, then an emergency department, then another hospital, just hoping that someone is unfamiliar with their history and they'll help provide some relief. We call that doctor shopping. The reasons behind it aren't always the same. Sometimes it is addiction, sometimes it's uncontrolled pain. Some people are just trying to avoid withdrawal, but sometimes it's a combination of all of the above. And that's the part that makes the opioid epidemic so difficult to address. For many people, it didn't begin with heroin or fentanyl. It began with a legitimate injury, a legitimate prescription, and a healthcare system trying to relieve legitimate suffering. There's also chronic pain conditions that can be especially difficult to treat because the pain itself doesn't always match what we expect to see on an exam. The first example is one that I didn't become familiar with until I saw it in the hospital setting. When you see somebody that breaks a bone and they have chronic regional pain syndrome or CRPS, these were some of the hardest patients to try and manage their pain. And it almost seemed like they were being super dramatic. Granted, they did break a bone, but there was absolutely no medication that could manage their pain for a broken wrist or a sprained ankle. Chronic regional pain syndrome is a condition where pain becomes dramatically out of proportion to the original injury. It usually affects an arm or a leg, and it can cause burning pain, swelling, changes in skin temperature or color, which is something that I witnessed in person. The patient's hand could be purple, and using a temporal thermometer, I actually saw a temperature difference. This includes decreased mobility and extreme sensitivity to touch. So, something as simple as clothing brushing against the skin or even casting and splinting this patient can be excruciating for them. Another example is one that we typically came across with patients that had traumatic injuries that ended up in amputation: phantom limb pain. Even when the limb has been amputated, the brain continues interpreting pain signals as if the limb is still there. Patients often described their pain as burning, cramping, or electric shocks to that body part that no longer exists. And it isn't imagined, it isn't psychological. It's a real neurological condition caused by the brain reorganizing after the loss of a limb. I found that it didn't always kind of flow like this, but our trauma patients ended up having way bigger struggles with phantom pain than somebody that lost their foot to diabetic necrosis, or they knew that the amputation was coming and they had time to process it. So it is a coping mechanism. As EMS providers, we often meet patients somewhere along this spectrum of complex medical history. We may not know whether the person in front of us is experiencing uncontrolled pain, withdrawal, substance use disorder, or some combination of all three. And honestly, it's not our job to figure out exactly where they fall on that spectrum. Our job is to treat the patient in front of us, providing appropriate care and recognizing that we're walking into a story that started long before we were dispatched. Before we move on, let's talk about some medications that you're most likely going to find on your patient's list, because not all medications work the same way. We're going to start this section with medications that you're most likely going to see in the medicine cabinets, and that is likely opioids. That includes medications like oxycodone, sold as roxicodone or Oxycontin, or combined with acetaminophen as Percocet or hydrocodone, which you'll usually see as Norco or Vicodin. These medications all work by attaching to the opioid receptors in the brain and the spinal cord. They don't fix the injury, but they change how the brain perceives pain. They're incredibly effective after surgery, fractures, and other severe injuries, but over some time, the patients can develop tolerance, meaning the same dose doesn't provide the same relief. One thing that's easy to overlook is that Norco, Vicodin, and Percocet all contain acetaminophen, which is Tylenol. So if a patient tells you that they took a handful of Norco, don't just think of it as an opioid overdose. You should be also thinking that the acetaminophen toxicity can cause some serious liver damage. Another medication that you're going to see quite a bit is tramadol or Ultram. People sometimes call it a weaker opioid, but don't let that fool you. It can still cause dependence and withdrawal. It also affects serotonin and norepinephrine, which means it can interact with antidepressants and in higher doses increase the risk of seizures. Switching over to medications that are not opioids, we have gabapentin or Neurontin and pregabalin, better known as Lyrica. These are commonly prescribed for nerve pain. They're great for conditions like diabetic neuropathy or shingles, but they won't do so much for a broken ankle or a rib fracture because that's not the type of pain that they're designed to treat. Both medications commonly cause dizziness, drowsiness, and sedation, so when they're combined with opioids or alcohol, that sedation can become much more pronounced, increasing the risk of respiratory depression. Then we have muscle relaxers like Flexeril or cyclobenzaprine, and Robaxin, methocarbamol. These medications don't reduce inflammation and they don't directly treat pain. Their job is to decrease muscle spasms. They're commonly prescribed for back strains, neck injuries, and rib injuries where muscle tightness is making the pain worse. Like gabapentin, they can make the patients pretty sleepy, especially when combined with alcohol or other sedating medications. Finally, we have NSAIDs, which stand for non steroidal anti inflammatory drugs. You guys are pretty familiar with ibuprofen, Advil, naproxen, Aleve, and prescription medications like meloxicam or Mobic. But unlike opioids, NSAIDs actually reduce inflammation. So if someone's pain is coming from swelling, whether it's arthritis, tendinitis, or that sprained ankle, they're treating the source of the pain instead of simply changing how it's perceived. So, why does all this matter? Because when you're taking a medication history, don't just ask, "What do you take for pain?" Ask what they take. If a patient's on oxycodone, they have different risks than somebody that's taking gabapentin. Somebody who mixed Flexerol with their alcohol may be way more sleepier than expected. And someone who says they took several Norco tablets may have an opioid exposure and a potentially dangerous acetaminophen overdose. So that brings us to Narcan. Narcan can only reverse opioids. It can reverse medications like oxycodone, hydrocodone, tramadol, although tramadol is a little more complicated because of its other mechanisms, and illicit opioids like heroin or fentanyl. It will not reverse gabapentin, Lyrica, Flexerol, Robaxin, ibuprofen, meloxicam, Tylenol, or alcohol. So, if your patient doesn't wake up after receiving naloxone, don't immediately assume that it failed. It simply means opioids aren't the only thing that's affecting this patient. Understanding these medications doesn't just help you memorize drug names, it helps you predict what you're about to walk into before you ever step through the front door. So let's follow what can happen to a patient over time. Maybe they hurt their back at work. They have surgery and they're prescribed Norco. At first, it's a game changer, and they can finally sleep through the night. They can go back to work and pick up their kids again. Life starts to feel normal. Then, a few months later, something changes. The same dose is not seeming to hit as well as it used to. That is called tolerance. The medication hasn't changed, the body has, and the brain adapts over time. So it takes more medication to produce the same effect. And that doesn't mean that the patient has done anything wrong. It's simply how our bodies respond to repeated exposure to many medications and even alcohol. As they continue taking it, something else begins to happen. Their body starts expecting that medication to be there. Now, if they miss a dose, they don't just notice it, they feel it. They can become sweaty, achy, restless, maybe even nauseated. And that is called physical dependence. Dependence is not the same thing as addiction. It is a normal physiological response that can happen with any medication, even when someone takes it exactly as prescribed. Now, addiction is different. This is when obtaining and using the substance starts taking priority over everything else. Work, relationship, finances, and health all begin taking a back seat because the substance has become the center of the person's life. Somewhere in the middle of all of this is craving. It's that constant voice saying just one more. Maybe it's because they want to get high. Maybe it's because they're trying to avoid withdrawal. Or maybe they're just trying to quiet the pain long enough to make it through another workday. Eventually, if the medication suddenly stops, withdrawal will begin. With opioids, patients often describe it as the worst flu they've ever had. They can sweat through their clothes, vomit, have muscle aches and goosebumps, and sometimes just an overwhelming sense of restlessness. It's miserable, but by itself, it's rarely life threatening. Alcohol is different. Alcohol withdrawal can progress to hallucinations, seizures, and delirium tremens, making it one of the few substances where withdrawals can actually become fatal without treatment. Understanding the differences do matter because if you can't tell the difference between someone who's tolerant, physically dependent, addicted, or actively withdrawing, it's a lot harder to understand the patient that's sitting in the back of your rig. And the more you understand what they're experiencing, the better equipped you'll be to treat both the medical emergency and the person experiencing it. Before we move on, I want to talk about something that's changed dramatically over the last decade: how we treat addiction. Years ago, it was often viewed as an all or nothing treatment. You quit or you didn't. Today, we understand recovery is a lot more complicated than that. And one of the biggest advances has been medication assisted treatment, or MAT. You'll probably hear patients talk about Suboxone or methadone, maybe even Vivitrol, and it's worth understanding what these medications actually do. So let's start with Suboxone. Suboxone is a combination of buprenorphine and naloxone. Buprenorphine is a partial opioid agonist. It attaches to the same opioid receptors as heroin or fentanyl, but it only activates them partially. That gives patients enough stimulation to reduce cravings and prevent withdrawal without producing the same level of euphoria. It also has what's called a ceiling effect, meaning after a certain dose, taking more doesn't continue increasing the opioid effect the way full opioids do, making it much safer from a respiratory standpoint. The naloxone portion is mainly to discourage the misuse. When Suboxone is taken under the tongue like it's prescribed, it has very little effect. But if someone attempts to inject it, the naloxone becomes active and can rapidly trigger withdrawal. And then there's methadone. Unlike buprenorphine, methadone is a full opioid agonist. It still activates opioid receptors, but because it's long acting and carefully dosed through treatment programs, it helps patients avoid the constant cycle of getting high, crashing, withdrawing, and searching for the next dose. Finally, there's Vivitrol, the brand name for extended release naltrexone. Vivitrol works completely differently. It isn't an opioid at all. It's actually an opioid blocker. It sits on the opioid receptors and prevents opioids from working. The catch is that patients have to be completely opioid free before starting it, otherwise, it can immediately trigger severe withdrawal. You'll still hear people say they're just replacing one addiction with another, but the evidence simply just doesn't support that. These medications reduce overdose deaths, decrease opioid use, and improve retention within treatment to give patients something they haven't had in a long time: stability. They don't cure addiction overnight, and they can reduce cravings and withdrawal enough that people actually participate in counseling. They can hold a job, repair relationships, and focus on recovery. At the same time, you've probably noticed another shift in healthcare: harm reduction. That includes things like needle exchange programs, fentanyl test strips, and take home naloxone kits. These programs can definitely be controversial, but understanding why they exist is important. Needle exchange programs aren't about encouraging drug use, they're about reducing HIV, Hep B, and Hep C, while connecting patients with healthcare and treatment resources they might not otherwise have access to. Fentanyl test strips give people an opportunity to identify fentanyl in counterfeit pills or other street drugs before using them. They are not perfect and they can't tell someone how much fentanyl is present, but they can reduce accidental overdoses. And then there's take home naloxone kits. The idea is simple: someone can't recover from addiction if they don't survive the overdose. Whether those kits come from EMS, the emergency department, pharmacy, or community organization, they're designed to give patients another opportunity to make it to treatment. None of these approaches completely eliminate addiction, but together they're helping keep more people alive long enough to have a chance at recovery. So, how does someone end up using heroin or fentanyl? Most of the time, it doesn't start with someone saying, "This seems like a good idea today." It might start with a prescription after surgery. Maybe they borrow a friend's pain pill until they get some back pain relief. Or it starts recreationally on the weekends. However it begins, addiction has a way of quietly moving the goalposts. One pill becomes two, weekends turn into weekdays, and what started as I'm choosing to use this slowly becomes I need to use this to feel normal. Then one day the prescription runs out, the doctor says no, or the next appointment is 3 weeks away. And at that point, the brain isn't thinking about insurance approvals or physical therapy. It's thinking about one thing: how do I make this feeling stop? So when someone offers to sell a few pills, it feels like a solution. Just this once, you say. The problem is that the pills on the street today often aren't what they claim to be. A tablet stamped to look exactly like Percocet, Oxy, or Xanax may actually contain fentanyl, or enough fentanyl to stop someone from breathing. For others, heroin or fentanyl simply become the cheaper, more available option. When prescription pills cost $20 or $30 each, street opioids can seem like the only affordable alternative. But fentanyl is about 50 times stronger than heroin and roughly 100 times stronger than morphine. That means that tiny dosing errors can have enormous consequences. Which brings us to one of the most important medications that we carry: Narcan. Naloxone or Narcan is what's called an opioid antagonist. That simply means is that it attaches to opioid receptors without activating them. Think of it like someone taking the last parking spot before the opioid can get there. Even better is that Narcan has a stronger attraction to those receptors than most opioids do. If fentanyl, heroin, morphine is already attached, Narcan can actually knock it off of the receptor and take its place. That's why it works so quickly. By blocking these opioid receptors, Narcan reverses one of the most dangerous effects of an overdose: respiratory depression. As those receptors are blocked, the brain begins to respond to carbon dioxide again, and the patient's breathing starts to improve. That's why our first priority necessarily shouldn't be Narcan. It should be oxygenation and ventilation. An opioid overdose kills because the patient stops breathing, not because they're unconscious. Open the airway, provide oxygen, and assist ventilations with a BVM if they're not moving enough air. Narcan does treat the cause, but good airway management keeps the patient alive while it has time to work. One thing newer providers are often surprised by is how patients react after Narcan administration. Sometimes they wake up calm and slow. Sometimes they're confused, angry, and trying to climb off the stretcher. Remember, if someone is physically dependent on opioids, you've just rapidly displaced the drug from their receptors. They may wake up in immediate withdrawal, and withdrawal is miserable, like we've previously mentioned. Another thing to remember is that Narcan does not remove opioids from the body. The drug is still circulating in the bloodstream. It's simply blocked from attaching to the receptors for a period of time. Once the Narcan wears off, those opioids can bind to the receptors again, and the patient can slip right back into respiratory depression. Pinpoint pupils are a classic identifying characteristic of an overdose, but don't anchor to these observations. If someone has mixed their overdose or has severe hypoxia, the pupils may not look textbook. We're also seeing far more polypharmacy or multiple medication use than we used to. Many overdoses aren't just fentanyl anymore. They involve alcohol, benzodiazepines, gabapentin, muscle relaxers, and the Narcan can only reverse opioid portions of that overdose. So if your patient is still altered after the administration, don't immediately assume that it failed or that it needs another dose. It may have done exactly what it needs to do, and the opioids may be reversed, but the alcohol or sedating medications are still affecting the patient. This is why airway management and continued reassessment remain so important. Because there's another scenario that we do worry about: re-overdosing. One way that it happens is when the Narcan wears off before the opioid does. The other is when someone uses the opioids again after they've been revived. Because naloxone is still occupying many of those receptors, they may not feel the effects immediately. Thinking the drug isn't working, they use more. And then as the Narcan wears off, all the opioids can suddenly bind to the receptors, leading to another overdose. That's one of the many reasons why EMS agencies carry leave behind or take home Narcan kits. These kits aren't just for the patient, they're for family members, friends, or anyone who might be there if another overdose occurs before EMS can arrive. At the end of the day, Narcan is an incredible medication, not just for its cure for addiction, but it gives people a second chance. Opioids tend to dominate the headlines, but if you've worked in EMS for any length of time, you know that there's another substance that we probably encounter just as often, if not more, and that's alcohol. Alcohol is built different. Not medically, it's absolutely a drug, but culturally. Think about it. Nobody questions grabbing a beer after mowing the lawn. Nobody thinks twice about downing champagne at a wedding or mimosas at brunch after the Sunday scaries. We don't just tolerate alcohol. We celebrate with it, bond over it, and some of our biggest milestones in life have alcohol sitting right in the middle of them. That's what makes alcoholism so uniquely challenging. Because if you're trying to quit opioids, you could avoid the dealer or have someone pick up your prescriptions. If you're trying to quit alcohol, you have to walk past it every time you go to the grocery store, gas station, you see commercials about it, and your coworkers invite you out for drinks after work. It's at birthdays, weddings, holiday parties, and it's woven into our everyday life. I don't think we appreciate how hard that makes recovery. People love to say, why don't they just stop? But the reality is, a lot of them have and are currently trying to, probably more times than anyone around them realizes. The difference is that we don't meet people on the days that they're winning. We meet them after the relapse, the fall, the DUI, or the fight with their spouse. We also run into them when 6 months of sobriety turns into one drink, and that one drink turned into 10. That's the chapter we get called to. We don't see the AA meetings they went to or the holidays they made it through without drinking. We don't see the nights they drove past the liquor store and kept going. We just get to see one chapter. And if we're not careful, we start acting like it's their whole story. From our perspective, alcohol is involved in far more than just intoxicated person calls. It's behind falls, assaults, domestic violence, motor vehicle crashes, hypothermia, burns, suicide attempts, and countless other medical emergencies. In the United States, excessive alcohol use contributes to more than 170,000 deaths every single year, making it one of the leading preventable causes of death. Long-term alcohol use doesn't just affect behavior. It affects nearly every organ system in the body. So, starting with the liver. The liver is responsible for breaking down the alcohol, filtering toxins, producing clotting factors, and helping us regulate our blood sugar. Over time, alcohol begins damaging liver cells. The first stage is often fatty liver disease, where fat accumulates inside of the liver. At this stage, the damage is usually reversible if the person stops drinking. If alcohol use continues, that can progress to alcoholic hepatitis, where the liver becomes inflamed. Patients may develop jaundice, which is the skin turning yellow, abdominal pain, nausea, fever, or elevated liver enzymes. Over the years, the inflammation can lead to cirrhosis, where the healthy liver tissue is replaced with scar tissue. Unlike fatty liver disease, cirrhosis is permanent, and as the liver scars, blood struggles to flow through it, creating portal hypertension. That increased pressure forces blood to find alternate pathways, producing enlarged veins called esophageal varices. You might not realize how frequently you're running into esophageal varices on scene. Those veins are extremely fragile and they can rupture without warning, causing massive upper GI bleeds. If you've ever responded to a patient vomiting large amounts of bright red blood with a long history of alcohol use, esophageal varices could be high on your differential. It's also important to remember that the liver produces many of our clotting factors. As the liver continues to decline, the patients lose the ability to clot normally, and what can seem like a relatively minor fall can result in significant intracranial hemorrhage. Next is the pancreas. Alcohol is one of the leading causes of pancreatitis. Patients often describe severe upper abdominal pain that radiates straight through to the back. They're nauseated, vomiting, and miserable. Repeated episodes can permanently damage the pancreas, leading to diabetes and difficulty digesting food. The brain and nervous system are affected just as dramatically. Over time, chronic alcohol use changes the way the brain functions. Patients may develop memory problems, slower thinking, poor judgment, mood changes, and difficulty with balance and coordination. Alcohol also damages peripheral nerves, a condition known as alcoholic peripheral neuropathy, kind of like diabetic neuropathy. Patients often complain of numbness, tingling, burning pain, or weakness that starts in the feet and slowly progresses upwards. One of the biggest reasons these neurological problems develop is malnutrition. Many chronic alcoholics consume most of their calories from alcohol while eating very little actual nutritious food. Alcohol interferes with the absorption of important vitamins, especially thiamine or vitamin B1. Without enough thiamine, brain cells can't produce energy normally. This can lead to Wernicke encephalopathy, a true medical emergency. Classically, these patients develop confusion, difficulty walking, and abnormal eye movements, although many won't have all three findings. If Wernicke isn't recognized and treated quickly with thiamine, it can progress to Korsakoff syndrome, causing profound, often permanent memory impairment. It's basically referred to as alcoholic dementia. Patients may repeatedly ask the same questions or unknowingly fill in gaps of their memory with fabricated stories, a phenomenon called confabulation. They're not lying. Their brain is trying to make sense of missing information. So this could possibly change their personalities. It could change the way that they remembered certain events happening. And when there's already tension with somebody that is an alcoholic, it makes caring for them sometimes rather difficult. Alcohol also weakens the immune system, increasing the risk of infections like pneumonia. It contributes to depression and anxiety and increases the risk of several types of cancers. Because it impairs judgment and coordination, it dramatically increases the risk of traumatic injuries. So, what does all of that mean for us? It means the intoxicated patient may actually have a traumatic brain injury. The patient who's vomiting may aspirate because they can't protect their airway. The chronic alcoholic who hasn't eaten in days may be profoundly hypoglycemic. The patient with cirrhosis may be altered because hepatic encephalopathy, where toxins like ammonia build up because the liver can no longer clear them effectively. And the patient who's trying to quit drinking may not be intoxicated at all. They may be progressing into alcohol withdrawal, seizures, and delirium tremens. That's why it's so important to not stop your assessment at they've been drinking. Alcohol may explain part of your patient's presentation, but it should never explain away the rest of your assessment. Before we finish, I think alcohol deserves one more conversation. When most people hear the word alcoholic, they picture a stereotype. Someone who's unemployed, drinking out of a paper bag, and obviously intoxicated all the time. But it's not always what alcoholism looks like. Some of the people struggling the most are the ones you'd never expect, that go to work every day, coach their kids' baseball team, pay their bills. They look normal. What people don't see is what happens when they don't drink. Because for many people with alcohol dependence, they're no longer drinking to get drunk. They're drinking to stay out of withdrawal. So they drink to stop the shaking, to calm the anxiety, and feel normal enough to get through another day. That's the important distinction. Someone who's drinking to party and someone who's drinking to avoid withdrawal are two very different patients. And as providers, one of the most valuable questions we can ask was, when was your last drink? Not how much are you drinking or are you an alcoholic? Just, when was your last drink? The answer can completely change your differential. If they had a drink 20 minutes ago, you're probably thinking intoxication, right? But if their last drink was yesterday morning and now they're shaky, sweaty, anxious, and tachycardic, you're probably looking at withdrawal. Withdrawal doesn't happen all at once. It usually starts with tremors, sweating, anxiety, insomnia. As it progresses, the patient can become increasingly confused and agitated. Some even begin hallucinating. Others can develop withdrawal seizures. The most severe form is delirium tremens, or DTs. These patients can become really confused, hallucinate, spike high fevers, or become really hypertensive and tachycardic. That's not someone who's just detoxing. That is a true medical emergency. Recover from alcohol use disorder also isn't a one size fits all. For some people, AA or Alcoholic Anonymous provides the accountability, structure, and community they need. Others find success through counseling, whether it be inpatient or outpatient, medical assisted treatment, or faith based programs. There's no single path that works for everyone. The goal isn't that everybody recovers the same way either. The goal is simply that they themselves improve their condition. You'll also see many of these patients receiving thiamine, magnesium, fluids, and sometimes dextrose in emergency departments. They're not just treating withdrawal, they're correcting nutritional deficiencies, electrolyte abnormalities, dehydration, and preventing complications. Alcohol may be legal, but medically, it's one of the most dangerous substances that we can encounter. And before we wrap this episode up, I want to leave you with one last thought. Because everything we've talked about today, chronic pain, addiction, overdoses, and alcoholism, it all comes back to this. These patients can be frustrating. There, I said it. If you've worked in EMS for more than a few months, you've probably recognized an address before dispatch even finishes reading it. Or you see a low-speed pursuit pop up on the MDT and immediately think, I know exactly where this is going. Maybe it's the same intoxicated patient you've picked up a half a dozen times. I've been there, and I know most of you guys have. The problem isn't having those thoughts. The problem is when those thoughts start changing the way that we assess the patient. It's easy to walk in thinking it's always the same thing. And honestly, sometimes it is. But every once in a while, it isn't. The alcoholic could actually have that subdural bleed. The drug seeker might really have a kidney stone, and the overdose patient might possibly be septic. The frequent flyer might possibly have something completely different going on than what they normally call you for. And that's why we experience a double-edged sword when it comes to providing patient care. Experience helps us recognize patterns, but if we're not careful, we stop seeing the patient and start seeing the pattern. Now, does that mean that every story you hear is true? Of course not. Some people manipulate, some people lie, and know exactly how the system works because they've used it a dozen times. That's just reality. But your assessment shouldn't change. One of the best pieces of advice that I ever got was treat every patient like they're telling the truth until your assessment proves otherwise. Not because people never lie, but because your assessment should be what changes your mind, not the assumptions you made before you even stepped out of the truck. Our job isn't to prove that somebody's lying. It's to figure out what's medically happening today, because today's call might not look like anything that you've seen at any of the last ones. And if you remember one thing from this episode, let it be treat the patient, not the pattern. Thank you guys so much for tuning in for another episode of Stretcher Fetchers. A little heartfelt thank you because you guys have put me at 1,000 streams. When I started this last year, I had no idea that I was even going to get a couple hundred listens. So from my heart, I hope you guys have a safe shift. And if you liked this episode, share it with a probie. Thank y'all and have a good day.